I want to welcome all those who are in attendance. And I want to acknowledge that this is hosted here at Stanford through the Center for Population Health Science, but this is an activity that's through the Persistent Poverty Initiative. And the initiative represents a collaboration of multiple centers, 5 centers, including Stanford, which is the upstream center, the Acres Home Center Cancer Prevention Collaboration at the University of Texas MD Anderson, and the Cancer Awareness Research Engagement and Support Center at the University of Alabama at Birmingham, the Center for Social Capital, SoCal, which is at the Weill Cornell and Columbia University, Irving Medical Center, SUNY Downstate Health Sciences University, and Hope and Care together, the University of Utah, Montana State University, and as I mentioned, us, and we're at Stanford, and we're hosting this today. Our center includes Stanford, UC Davis, and UCSF. So I have the pleasure today to introduce Tanea Thomas, who's an assistant professor in the Department of Epidemiology and Population Health here at Stanford, and I'm fortunate enough to be her chair, and it's been a real pleasure. Dr. Thomas is a social epidemiologist whose work focuses on primary care improvement and on diabetes prevention and management among racially and ethnically diverse populations. She leverages delivery science and community engaged approaches to integrate evidence-based interventions into clinical practice and advancing health equity. Dr. Thomas completed her master's and PhD in public health at the University of North Carolina at Chapel Hill, where she focused on health behavior and health disparities. She's since built a robust portfolio of research on diabetes prevention and chronic disease management in under-resourced communities with work published in leading peer-reviewed journals and increasingly shaping practice and policy to make primary care more equitable and responsive to the needs of diverse populations. She's a dedicated mentor, collaborator, and working closely with trainees, community partners, and health system leaders to translate evidence into real-world impact. It's a real pleasure to welcome Dr. Tanea Thomas to give her talk today. So thank you, Tanea.
I will get started. So today I'm going to be talking about who gets a say in real-world data and really thinking about how we might use some community engaged research principles for electronic health record and other real-world data studies. I have no disclosures. Okay. So I am going to start this with a tale of 3 stakeholders. So here's a scenario. So the American Diabetes Association and the European Association for the Study of Diabetes released a joint consensus statement that recommends that patients with type 2 diabetes and CVD or CVD risk factor initiate a SGLT2 or GLP-1. So this happens. Here we have Dr. M. She just came back from ADA like me and learned all this information about these new diabetes medications and how they can improve outcomes for our patients, and has decided that she wants to get more patients in her clinical practice on these medications. Here is Mr. C. He came in this week for his diabetes checkup, and he has some CVD risk factors. And so Dr. M was super excited to chat with him and tell him about this new medication that she wants him to initiate. And because his brother had a stroke, he is really interested in preventing strokes. So he said, you know what, I will try this new medication. And then we have Dr. J here. He is a health system leader. In his meeting on Monday, he was told that health system costs have tripled in the last quarter and that they need to figure out sustainable ways to reduce health system costs. And then in his meeting on Wednesday, he found out that another clinical partner shared that some of their Black patients have have suboptimal diabetes outcomes, and the health system needs to do something about that. So we're going to come back to our stakeholders, but this is where we are. And so, most of the recommendations for engaging patients in research focus on intervention studies. This is often because intervention studies have clear phases for engagement related to recruitment and intervention development that have been well detailed. And so we've used community engagement principles for those for, the past 30 years. However, observational data studies often involve these complex data and complex methods, and sometimes people feel like this poses a challenge to stakeholder engagement. In addition, recent guidance from JAMA on reporting race and ethnicity in research study highlights that there are concerns, sensitivities, and controversies in reporting associations of race and ethnicity with health outcomes. The authors rightfully propose that we need to better disentangle the roles of race, ethnicity, and structural, socioeconomic, and institutional factors in health outcomes. And so, how do we do that? So, for example, let's say we have an observational data set and we see a disparity. In the example I just gave, we see that Black patients in the healthcare system have suboptimal outcomes or are less likely to meet their glycemic targets. What does that mean? Why is that? Are we going to say it's because of genetics? Are we going to say it's because of discrimination? Are we going to say it's because of access to care issues? And so what I'm really interested in is how can we better understand the reasons for disparities that we see so that we can design the appropriate interventions. And so that led me to leverage some well-established community engagement concepts to develop some principles for actively engaging stakeholders in observational clinical research. I call these the coordinate principles. And so I will start to go through them. So the first principle is co-learning on the structure and use of observational data sources. So observational data often utilizes electronic health record data that reflect patient care as documented by healthcare professionals. Unfortunately, patients' perspectives are largely absent in this data. Most of the time, we do not invite patient partners to discussions of how to interpret their own data and how we might use their data resources. And so our recommendation is that we should bring all relevant system stakeholders, including patients, together as part of one group when discussing the structure and use of observational clinical research data. And this is because it gives us an opportunity to do co-learning together. Sometimes people have separate patient groups, separate clinician groups, separate health system groups. And we think like, oh, it might be hard to get everyone together to have these sorts of discussions, but we've done that successfully and have found that our clinicians actually do really want to hear from our patients. Our health system leaders want to hear from patients and clinicians, and we've had a lot of robust conversations. And so back to this example. Mr. C, our patient partner, could provide important context on his care, and he's given an opportunity to really understand how his pooled individual data is used. Dr. M can provide perspectives on the strengths of how data are documented in the electronic health record. So for example, we might see some missingness in our data set and just assume that this service is not happening, but perhaps we talk to a clinician who says, oh no, that's actually documented somewhere else, and that gives us an opportunity to see what's actually happening in clinical care. And then Dr. J can discuss how patient and clinical data are used to set health system policies and metrics in ways that help us better understand what we should be doing. And so having all parties in the same room facilitates these meaningful discussions and the interpretation of clinical data for research and helps us use the wisdom of the group to develop cooperative strategies to improve health equity, cost, patient experience, and quality of care. The second principle is valuing lived experience equal to scientific expertise. So researchers may believe that observational research studies are too complicated to explain to patients without statistical methods training. Sometimes we feel like they're too complicated to explain to people outside of our field. And what we have found is that occasionally people will just decide not to do any engagement at all because they think it's complex. I'll give you an example. In a qualitative study conducted in 5 U.S. cancer centers assessing factors influencing the recruitment of racial and ethnic minoritized patients for cancer clinical trials, found that PIs and referring clinicians viewed racial and ethnic minoritized patients as less promising clinical trial participants and reported withholding trial opportunities from them because they said that they didn't think that they would understand the study and they didn't have the time to explain it to them. So this has real implications in the work that we do. And so research is more actionable when it leverages the experiences obtained from people with lived experiences. And so our recommendation is actually that it is on us, the researchers, to distill our core research ideas into easily interpretable, non-specialist terms so that all of our partners can participate in the research design process and ensure that our aims, methods, and outcomes are accessible to the populations with differing lived experiences. And so it's really important that we think about how are we presenting our science and how are we engaging others in that, and have we used the appropriate terminology to allow people to engage in our research. And another piece of this that I just want to mention that is also important for us to make sure that we are paying our patient and community partners. We don't ask our co-Is and consultants to join our projects for free, and we shouldn't be asking our patient and community partners to do that either. And that is part of valuing the lived experience equal to the scientific expertise. And then the last principle is involving our stakeholders in the research continuum and seeking patient insights to interpret our study findings. And so in order to effectively do principles 1 and 2, we need to make sure we have structured opportunities for our stakeholders to provide study-related feedback. And so part of that is that can help us. A lot of times we might do this in our aims, sometimes we might do this in our measures, but I will say it's also really important for us to think about how we do this in interpreting our findings. Because sometimes without proper contextualization, our findings about any disparities that we find in our work may increase stigma and bias towards already marginalized populations. And what we really want to do is support a more nuanced and meaningful understanding of whatever observed disparities that we see. So for example, an example that we've been talking about, we could perhaps hypothesize in our conclusion section of our paper and say that, any disparities that we see in our health system among Black patients are because these patients aren't compliant or whatever we might say, right? But is that really what the case is? And how can we make sure we are not perpetuating biases? Because once we publish that, the next person may say, oh, well, they found these findings are likely related to patients being, not adherent, and now we perpetuated that. So can we think about the true reason for our findings through engagement? And so this is our recommendation that at each stage of research, we consider the relevant questions for stakeholders and elicit feedback. And then that we also provide regular updates to them on how we've incorporated their input. The last thing you want to do is spend 5 years doing, quarterly meetings with the group, and you never let them know how you've used their input to change the science to inform your research design. You want to make sure that you're letting them know that their expertise is valuable, that their time is valuable, and how it's impacted your study. And so now I'm going to give you an example. And so I have 2 examples that I'm sharing. This first one is data that is informed by partnerships, and the second one is going to be focused on partnerships that are informed by data. So we're going to go both ways here. And so on Target DM is a PCORI-funded parent study where we have 6 different sites that are part of the Healthcare Systems Research Network. And so the real goal of our study were we have these two newer classes of diabetes medications. And we were really interested in thinking about generating evidence to help patients who have a moderate heart disease risk choose between 4 drug classes and their timing. And so the 4 drug classes are these 2 newer classes and then 2 older classes, DPP4s and sulfonylureas. And so it was set in 6 health systems across the US, all integrated care systems. And then this is just a cross section of one of our study years and a sample size by race ethnicity. So it's a pretty diverse sample. And so we recruited 19 stakeholders across our 6 health systems. As you can see here, we had mostly patient partners, and that was very intentional. But we also tried to have a diverse spread of stakeholders, so between caregivers, diabetes educators, pharmacists, clinicians, and then health system leaders. And then we had 6 sets of meetings planned over 3 years. So we met over twice a year. And we actually ended up getting some funding to do a seventh meeting because we thought it was really important to really think through our dissemination strategies. And through our meetings with our stakeholders, we heard a lot of themes around costs related to these newer medications, access issues, and then equity issues. And so just to give you some examples, so let's go back to our tale of three, our scenario, our stakeholders that we talked about. So here, Dr. M increases her prescribing of these newer medications in her clinical practice, but for whatever reason isn't seeing much change. Then she starts getting complaints from her patients who went to their pharmacy and couldn't get the prescription, or went to the pharmacy and found out it was quadruple their normal copay and couldn't afford it. Now she stops prescribing these medications. Okay. Mr. C took his new prescription to the pharmacy, super excited about it, only to find out that it wasn't available and they weren't sure when it was going to be back. So we might look at his data and see that it was prescribed, but then it wasn't dispensed. And then we might make all these reasons for why it wasn't dispensed and not know that it was an access issue. And then here is our health system leader. As I mentioned, he's worried about cost. He is also worried about disparities in his health system. So hearing directly from both Dr. M and Mr. C could help him think about what are the appropriate strategies to implement at the healthcare system level to address these care gaps. Specifically in our study, here are some of the things that our partners have told us. So this patient explicitly told us that sometimes people will not choose to take their medication because they can't afford it or it's too much. And then they have to decide, what do I do? This patient gave a really clear example about access issues to Ozempic. Can you imagine trying to go to 5 different pharmacies across state lines, trying to get your medication and not being able to do so? And think about the time that took and that not everyone has the time to do that. Next, I'm going to talk a little bit about how we incorporated the stakeholder feedback from our 6 meetings into our study. The first thing we did was we made a study infographic that we sent out prior to each meeting. We kept saying, DPP4s, SGLT2s, and our patient partners were like, what is that? Can you give me an example of that again? What is that medication? And so we made this infographic so that we can help orient them in the project every single time, because they are not thinking about this every day, and reminding them of what our outcomes are and reminding them of who's involved and what we're hoping for. And so this really helped us stay on the same page, and every time we meet, be on the same page so that we can engage in conversation. The next thing we did is, so our PCORI-funded study, we were required to study 3-point MACE as part of our outcome, but we knew that there were going to be other key secondary patient-centered outcomes. And so we selected those based on stakeholder feedback. So in one of our meetings, we literally had them rank which were the most important secondary outcomes they were interested in. And then we did select the top 2 for secondary analyses and pursued those. But what I also want to say is then we asked them kind of what made you choose these outcomes. And then we had a really nice discussion actually about depression. So this patient talks a little bit about we have to let people know if their medication might have the risk of depression, because a lot of people aren't willing to become depressed again. And so they might be, willing to, they might want to be on a different medication instead of risking some new incident depression. While another patient said, actually, I already had a heart attack and I'd rather be depressed, and I'm actually more depressed than ever, but I feel better. And so there are these opportunities for us to think about, what does patient-centered care look like and what type of information are we sharing with our patients when we're helping them make decisions on which medication to take. And because of this discussion, our clinical and health system leader said, actually, we think this is an important outcome and we should look at that as well. And so we actually did recently publish a paper looking at the comparative safety of these medications on depression among adults with type 2 diabetes. And so that's kind of how our partners and our stakeholders influence the study and influence what we looked at. We also asked them once they decided on these measures, on these outcomes, what should we be measuring? How should we be measuring? Do you want to see BMI changes? Do you want to see actual change in weight? Do you want to see trends in weight change? So right now we have a paper under review. They selected trends in weight change because they thought that that was going to be more actionable. So now we're assessing that. When we asked them about measures of renal function, our all our stakeholders basically said, well, what do they say in the literature? We actually don't care that much. These are a little bit complicated and they both have different values. So we looked at both. So we ended up looking at both for this. And then every time we have a paper come out, we develop an infographic that summarizes the publication and we send it to our stakeholder group along with the paper. So that is one of the ways that we are disseminating our study findings. And so here is our team who is fantastic. And here is our funding. And then now, briefly, I am going to talk a little bit about another example. So I just talked about our data being informed by partnerships. Now I'm going to talk about building partnerships based on the data that we have. So the example that I shared with you was PCORI-funded. And because of that, we already had our stakeholder committee set. We had to have a stakeholder engagement plan set. We knew everything that we were going to be doing with our stakeholders going into the study. But that doesn't always happen, right? Sometimes you just did some analyses and you found something interesting and you're like, oh, what should I do next with this? And that's what I'll talk a little bit about here. So back in 2022, we conducted a study using Kaiser Permanente Northern California electronic health record data to geospatially map people with prediabetes. And this was part of a larger study that was assessing the implementation of a policy that requires Medi-Cal that requires health plans that have Medi-Cal beneficiaries to offer the DPP program, the diabetes prevention program, free of cost. And so we thought one thing that we could do and we could contribute is to see where are we seeing any of these potential prediabetes hotspots, because that might be a place where we might want to scale up some of these diabetes prevention programs. And so our study population was 760,000 adults who were eligible to be screened for type 2 diabetes. And our main outcome was seeing who screened for a prediabetes range lab value. And then we defined kind of this hotspotting as an area with significantly higher rates than neighboring areas. And so we found that about 40% of our screened adults had prediabetes, and they were concentrated in the 7 hotspots in Northern California in these counties. So these are our findings, and we could have stopped there, but we started looking at correlates of living in a prediabetes hotspots. And so we found some interesting, race and ethnic differences there and some household income differences and some differences in receiving Medicaid or not. And then we thought, okay, well, what do we do with this, right? We have this, we wrote the paper, we could have moved on. But then we decided, like, this is an opportunity to actually start building community partnerships in these counties where we found that there's an increased prevalence of prediabetes. And so I ended up reaching out to Santa Clara County's Department of Public Health. They have a diabetes prevention initiative and wellness collaborative, and I just started going to the meetings. And I let them know that, we identify Santa Clara County as a prediabetes hotspot and would love to know more about what you're doing and what your priorities here. And this happened at the perfect time because they happened to be working on their 5-year strategic plan when I reached out to them. And so they invited me to become a part of the strategic plan and to help them with some of their goal setting. And we are currently working on implementing that plan right now. We've submitted multiple funding proposals together, and we have an ongoing pilot right now that's focused on moving one of the strategic goals forward. And, all of this happened just because we identified them, we used our data, we identified them as an area where we might want to, scale up some diabetes prevention work, and they were interested. And it's really grown. I mean, I've been working with the collaborative for 4 years now. I, go to all their meetings. We meet separately outside of the larger collaborative meetings. Through that, I have built partnerships with other community-based organizations in Santa Clara County. I'm putting in a grant next week with one of those organizations. And so it's really spread spreading. So this is a really nice opportunity to think about how we might use our data to build partnerships. And the beauty is Stanford has a lot of pilot funding opportunities. So if you're thinking about how you might want to build a out of collaboration or work with a new partner, there are lots of little pots of money to help you do that and set that up. And I would really recommend, working with the School of Medicine's Office of Community Engagement. They do a lot of work in this area, both in terms of pilot funding, but also just doing consultations. So if you're like, I don't know where to start and finding a partner, they could help you there. And so I just want to leave you with that and say thank you so much and am happy to answer any questions.
Thank you, Tanea. What a great talk. Thank you so much for presenting today. Let's open it up for questions.
Excuse me. At the beginning, you had a QR code. Would you mind going back? I would love to scan it.
Oh, of course, of course.
Thank you.
Let's see if I can do this seamlessly. Probably not, but I'm gonna do my best. Yeah.
Any other questions while she's pulling it up?
Can we ask questions? Of course. I have a question, by the way, this is amazing.
Can you speak a little bit louder?
Yeah, oh, okay, I see. You can sit in here now. You can sit.
Oh yeah, come on over.
Just want to say this is very, I just love the work that you're doing and it's very amazing. One of the questions, one of the questions that I had was about, you said paying for your paying participants, right? And how do you balance that when, because yeah, definitely we want to pay them, but how much it's appropriate, and also how do you balance that with like IRB and ethical concerns in regards, because I think IRB, they may say like, oh, this is too much, because then it will be considered coercion, I believe.
Right.
So how do you balance?
So I think about that in terms of the time that we're asking people to give, how often we're asking them to meet, kind of what the bar is. We actually had PCORI tell us that we were paying our patient partners too much and that we should give them less money. So, because we did start off high. It was a 2-hour meeting and we were going to give them $250 and they were like, whoa, that's way, but we're like, we're giving our clinical partners $250. So and no one said anything about that. But so we ended up reducing it. But I will say, it really depends on the ask and the budget. Sometimes people are happy, like if you provide food at the meeting or something like that as an incentive. We've stayed, depending on the ask, in like around the $50 range, and depending on who else we're talking to. But I mean, I think it depends on your budgeting, the population, and how much time you're gonna be asking them to participate in something. We wanted to offer more money because we're sending out things in advance. They're gonna spend time looking at it in advance in addition to the meeting, and we wanted to honor that kind of pre-work time. But sometimes if you're not asking for any pre-work time, you don't have to give enough money. And the IRB will definitely let you know if you are, recommending too much money. So I personally err on paying people more, and then I see if there's pushback. But I think they're really valuable and they deserve every dollar that we offer them.
Absolutely. I agree with you on that. Thank you. There's the question from.
I can't hear any of this. Is there somebody talking?
I have a question.
I know you do. Can Daniel ask the question today or somebody else?
Oh, yes, again.
Thank you for an excellent presentation. We do similar studies on cancer, trying to overlap with diabetes and obesity. My concern is the new drugs that you're recommending. Are they based on studies that included the populations of ethically deprived that you want to apply them to? Because we find out in cancer studies, often the original trials are very limited And I always worry about, well, how do these results apply to the patients that you're gearing these to?
That is a great question. So our comparative effectiveness study used and listen, these I'm going to tell you briefly about our methodology, and these are questions for someone else because I am the engagement person and not the statistician. But we did do a target trial emulation in our healthcare system with our diverse patients. And so we were actually able to replicate comparative effectiveness, RCT, in our healthcare system and actually feel confident in saying that like we had a diverse sample. That's why I showed you, I shared who it was, in that our findings were robust for across all of our racial and ethnic groups. And we did
Thank you.
sensitivity.
That's so important because we're not finding that in our cancer studies. Native Americans are hardly ever in any studies, and poor people don't have the money to even get in the original studies. Thank you.
Of course.
Any other questions?
Great presentation. Thank you so much.
I think, Tanea, which, I think the example you gave, and I know that Daniel just mentioned, some of the things that we do in cancer may not be exactly the same, but I think the important part here is, and why we were hoping you'd speak, is that it's transferable to cancer. And I think you're also open to collaborations. That was the other thing that I wanted to mention. I don't know if that's what's in your QR code, but I know that Tanea is definitely a very collaborative person and would be happy to talk to any of you in terms of potential collaborations.
Absolutely. Melissa's right. I do engagement across a number of health outcomes, so would be happy.
Oh, well, for all of those of you who attended from Stanford to New York to Alabama, all of you, thanks for coming. We will probably be continuing these throughout the next year with the other persistent poverty centers. The plan of how it's going to be moved around from one center to the other is still under discussion. But thank you all. And if you have ideas, please send them our way or to the people from your center, so that we can incorporate some of those speaker ideas into the planning for the next school year.
And yes, I see some comments in the slides. I love, someone talked about how they compensate their study teams. I love some of the things that are in here about building up the ecosystem of trust in healthcare. Thank you. I saw something about access to the slides, and we will be sharing them after a PDF copy of the slides afterwards. So, and this is being recorded, and I think they'll be sharing this as well. So, yes.
One of the things I wanted to mention, since no one else is speaking right this second, I love your infographics. And I that was one of the things I picked up that I don't think we do. And I really enjoyed that example a lot. So thanks for sharing that part.
Of course. And I have a question about how can students contribute? I take on, so we have, well, let's see. I'm like, we had a program, but I'm like, oh, it's an interesting time. But we often take summer students. I want to talk about the AHEAD program, and I was like, wait, okay. We have, some of us do take on students during the summer. So if you want to engage in a PI, I teach, actually, along with Lisa Goldman Rosas, teach a class in EPI called the Science of Community Engagement and Health Research. It's EPI 272. So if you could take our class, and we go through this in much more detail, we go, but not just for observational studies, just community engagement overall. And we invite community partners. We try to do that based on student interest. We sometimes have a community partner co-teach a class with us. So there are a lot of opportunities to really learn about the science of community engagement in that course. I would say it's highly recommended, not just because I teach it, but I do think it's like a really great course. So that is one way. And if you're interested in any particular topic, I would just feel free to send me an email. And if I know someone who does work in that space, and particularly community engaged work, I'd be happy to connect you.
Anything else? Tanea, thank you so much. I'm sure I'll see you in the next day or so. Great. Thanks, everybody. Have a good summer for those of you who we won't see. Thank you.